So next we invite Dr. Abhishek Ranjan to talk on outcome of TENONS patch graft in corneal perforation with overlay sutures.
Okay. Good morning, everyone. I have no financial interest. So corneal perforations are common corneal emergencies across the globe, and multiple management modalities are available. But most of them require an eye bank support or availability of tissue adhesives. Tenon patch graft is a technique which is not dependent on these factors, as the graft is harvested from the same eye of the patient. All the published literature used either fibrin glue or cyanocolate glue with or without suture application. The aim of our study is to know the outcome of TENONS patch graft in corneal perforation with overlay sutures without any glue. So this is a retrospective study approved by Institutional Ethics Committee. 29 eyes of 29 patients were studied who underwent surgery between March 21 to June 23. Corneal perforations of 2 to 6 millimeter larger diameter who have followed up for minimum 3 months were included in the study, and cases with active bacterial and fungal keratitis were excluded. Anatomical success were assessed at minimum 3 months follow-up when structural integrity was restored with formation of a scar and anterior chamber. Patients were counseled regarding the primary goal of the surgery and natural postoperative course of the procedure. The need for secondary procedure was also explained, and written consent were taken. Briomidine tartrate were instilled before surgery 5 to 10 minutes prior to surgery to achieve vasoconstriction. All the surgeries were done under peribulbar or subtenant anesthesia. So this is the video. So first we have debrided the loose epithelium, and TENONS graft were harvested from one of the quadrants. Then this tenon graft is well spread over the perforated area, and 10-0 nylon suture is passed through the cornea over the TENONS graft without touching the graft. And suture is given in infinity manner. The limbs of the infinity suture must cross the area of the perforation. And the TENONS graft is then well tucked under the suture. Then anterior chamber is formed with the air and saline, and bandage contact lens was applied at the end of the surgery. In post-operative period, tapering doses of topical steroid over 4 to 6 weeks were given along with prophylactic antibiotic in initial post-operative weeks or until the BCL is removed. The management of underlying disease is continued as appropriate. Patient was followed up at post-op day 1 week, every 2 to 3 weekly 3 months, and monthly after that, and ASOCT were done at each visit. BCL was removed after epithelialization, and suture removal was done after a scar formation or if suture get loosened. So this is the course of healing, and you can see in the post-operative period, ASOCT shows that there is integration of TENONS tissue in the corneal tissue with the formation of a scar. So coming to the results, so mean age of the patient is around 41 years, out of which about 60% were male and 40% were female. Most of the cases were resolved infective keratitis. So mean size of corneal perforation was about 4 millimeter. Mean follow-up period was about 29 weeks. Mean time of epithelialization was around 4 weeks, and mean time of scarring was 14.42 weeks. Anatomical success were achieved in around 90% of the cases, and failure was seen in 10% of the cases. So coming to the discussion, TENONS tissue is produces autologous fibroblast, which because it is autologous, there is no risk of infection or immune reaction. It is inexpensive and readily available. So with other studies which used glue shows successful restoration of globe integrity in about 74 to 90% of the cases. In our study, anatomical success were achieved in about 90% of the cases. Other studies shows time of epithelialization is about 2 to 5 weeks. In our study, it is around 3 to 6 weeks. Time taken for a scar formation, that is TENONS patch graft is integrated into the corneal tissue, is about 12 to 20 weeks in other studies, while in our study it is around 10 to 18 weeks with a mean of 14 weeks. Failure was seen in 13% in other studies. In our study it is around 10%. So to conclude, TENONS patch graft is a simple and effective procedure that does not require backup of an eye bank. It can be performed in a small to moderate sized corneal perforation which do not have active suppuration. It restores the tectonic support and reestablishes a stable ocular surface. TENONS patch graft with overlay suture without any glue is a very convenient and cost-effective technique with a low rate of postoperative complication, making it a viable option, especially in areas with limited resources. Outcome is comparable to TENONS patch graft with the use of glue. Thank you.
Yeah, that's quite impressive because all sorts of, I'm a big fan of TENONS patch graft myself, and I have used it in many methods with fibrin glue, with synovial glue, with sutures, everything. The only question I have for you is most of the eyes with perforation will have iris plugging the perforation.
Yes, ma'am.
So when you use a TENONS patch graft with overlay sutures alone without glue, like you showed in your video, you have to cover a little bigger area than the perforation. You have de-epithelized the area around the perforation and you put the graft and taken the overlay sutures.
Yes.
How will you go about repositing the iris? Because the area of perforation and the area of graft are little larger now. So your visibility of the anterior chamber is not there. You have empirically inserted an air bubble at the end of the procedure. So how are you going to reposit the iris which has plugged the area of the perforation?
No, in cases where iris is plugged, in that cases after putting that TENONS graft or depending on the size of the graft, size of the perforation, either we unplug the iris before putting the graft, or it is easier to first put the TENONS patch graft, suture it, and do with the side port, and with the iris repositor just swipe it, and iris will get out from that plugged area, and you just put an air bubble and put a BCL.
Totally agree. That's how we do it as well. It is much more controlled to put the graft first, secure the perforation, and then go through the side port and sweep it. For the same purpose, I am asking you that your method of sealing involves a little bigger area. So with a bigger graft and overlay sutures, don't you find it difficult to visualize and reposit the iris in the sweeping step, which you do after plugging the perforation?
So that is the air bubble is a very good guide for doing that thing. If air bubble is gone all through the anterior chamber, that means there is iris is not into that perforated area. If if air bubble is somewhere, it is like in patchy manner air bubble is there, or if you see discontinuous air bubble is there, in that case we suspect that iris is still in the perforated area and we have to re-swipe it. And
One of the
again,
long-term issues with the TENONS patch graft is vascularization. It invites intense vascularization in the healing period when it forms the scar. Have you seen the vascularization to be on par, more or less with this kind of technique?
I feel it is lesser vascularization than cyanoacrylate glue. At least with the cyanoacrylate glue, there is a lot of vascularization. But if we put the TENONS patch, if it is in peripheral area.
What's your follow-up?
Pardon?
What's your longest follow-up?
Longest follow-up is around 6 months.
What size of perforation could you treat with this? Because larger perforation will be a difficult.
Till 6
The
millimeters.
larger perforation you
Till 6 millimeters, sir, that is in our inclusion criteria. Till 6
larger perforations you will have to at least plug the perforation, then only it will.
Yeah, so in larger perforation we have to do for a patch graft or like that.
So ma'am, do you recommend using endo illuminator for increasing the visibility?
No, the endo illuminator will still not give you any view in the area that you have treated. It is a little larger area. Whenever you opt for an onlay, immediately it increases the size of the graft rather than an inlay. So if you use an inlay with glue, you are limiting the size of your graft. So you have much more clear cornea around for you to view. The endo illuminator, while it will give you view when the view is hazy, when the view is completely blocked with TENONS, you cannot see below it whether the iris is attached or not. That is my only objection to this technique. If there is no iris attached, then this may work, but that is hardly the case in the perforation. Usually you will have a plugging of the iris.
Correct.
So even with the iris is plugged there, then we have to get adherent glaucoma there, and maybe we can at least restore the globe at least.
I agree with you.
Yeah.
I agree.
Yeah, thank